Sign in your name, FB account, email address in the chat box. Include the names of your companions in the room. Use the chat box to ask questions and make comments while the pep talk is on. We will have group pictures at the start and end of the pep talk. Okay, so show your face in the video. Remember to take the online learning CUM evaluation test exercise for mastery of learning and have a perfect score to get a certificate, as shown on the slide. The link, I've given it in the chat box. Okay. So let's now have a group picture taking for a few minutes. Show your face.
Lim.
Okay. 1, 2, 3. Okay. So let's, I think we need another page for this. Wait. Page 2. 1. 1, 2, 3. So try to get pictures only in your end, at your end. I have a patient empowerment program in which I would like to empower the lay people or patients to take control in the management of their health. I launched this pep talk on May 15, 2021 with a module on COVID-19. The second module was on patient empowerment. We just finished it last week. And the third module is entitled Patient Management Process. We're now at the start of this particular module. There are 6 parts or episodes in this particular module, namely overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patients process, peculiarities and limitations of medical practice. What I have in mind in my pep talk program, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. That is my performance, key performance indicator. I hope you will be within this group of 30. My pep talk today will focus on patient management process, an overview. The objective is for the lay people to have an understanding of the patient management process, how a patient is being and should be managed. I'll give you 1 second to have a quick glance at the framework of the patient management process so as to prime you on my talk, but I will not discuss it yet as I want first to do a little introduction and give a little backgrounder to the framework. A patient in the medical context is someone who has a health concern. That health concern has to go through the processes of problem solving and decision making to know what it is first, or the so-called diagnosis, and then to know what to do to resolve it, or treatment. This, in essence, is the gist of patient management process. As early as 1989, I formally formulated a patient management process framework or algorithm, which I've been using since then in my private practice and in teaching medical schools and hospitals. Modesty aside, I find my PNP simple and practical to follow, and to teach both healthcare professionals and the lay people. Although this framework was originally made with the healthcare professionals, namely physicians and medical students, in mind, I honestly think it can be used to teach and should be taught to lay people so that there will be alignment of expectations from both parties, namely, or meaning the physicians and the patients. In understanding the patient management process, lay people like you will know how to participate in the problem solving and decision making of their health concerns with their physicians. First and foremost, they will know what to ask. I repeat, what to ask the healthcare professionals before they make decisions on their health concerns. Second, they can evaluate whether the healthcare professionals are using proper and rational processes or not. When you say not, example is that they are just using matching type questions and answers to make recommendations. This could serve as a ground to seek second opinion from another healthcare professional. In understanding the patient management process, even in the absence of a healthcare professional, the lay people may know what to do with their health problems, at least the processes in problem solving and decision making. So with this competence, they can gain greater control on what to do with their health concerns and issues. Now, do all the above benefits of patient management process remind you of the concept of patient empowerment? For those who have attended the module last time, okay? So pagpapalakas ng pasyente through the K4, kaalaman, kakayanan, karapatan, and kapangyarihan. A word about using processes versus using matching type questions and answers in problem solving and decision making. In matching type questions and answers in solving problems, you have premises and then straightforward responses. Okay, the responses that you choose to answer the premises. For example, if you have this symptom or set of signs of symptoms, then the diagnosis is this or that. If you need a paraclinical diagnostic procedure for a particular diagnosis, then the procedure should be this or that. Likewise, in treatment, it will be this or that for a particular type of diagnosis. So this is an example of the process of matching type questions and answers. The problem-solving and decision-making processes for health concern are more complex than performing matching type questions and answers, as we shall see later on. By the way, and suffice for me to say at this moment, a process is defined as a series of actions which are carried out in order to achieve a particular result or a goal. Here again is the diagram of my patient management process, framework, or algorithm. For today, I will just present the gist or a summary in each step and the involved processes. I will do the detailed discussion in the next sessions. The patient consults a physician. The goal of the physician is resolution of the health problem in such a way that the patient does not end up dead as much as possible with no complications and no disability, and in such a manner that the patient is satisfied. These are the universal goals of all physicians, and these are also rightfully the expectations of the patients. Again, a patient consults a physician. What are the 4 basic categories of functions or tasks expected of a physician? Rapport, diagnosis advice, treatment advice, and then advice. The general quality standards that can be used for these 4 tasks are rational, effective, efficient, and humane. After establishing rapport with the patient, the physician starts accomplishing the task of diagnosis. The physician does interview to get symptoms data and does physical examination to get sign data, after which he does the clinical diagnostic processes to come out with the clinical diagnosis. The clinical diagnostic processes consist of pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or a pattern of a disease. Prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and system. Illustration 1 for clinical diagnostic process. If you know the common manifestations of 5 different diseases as follows. Disease A, I just put it representatively in terms of of the alphabet. A, B, C, D, okay? And then disease B, F, G, H, I. Disease C, K, L, M, N. Disease D, P, Q, R, S. Disease E, U, V, W, X. So given a patient manifesting with PQRS, your diagnosis is disease D, disease D, as in dog. What is the process used? Pattern recognition. Illustration number 2, knowing the common manifestations of 3 different diseases and relative frequency of each as follows. This is A, ABCD manifestations, but it is the least common among the 3. This is B, the same manifestation, ABCD. Then this is C, ABCD, also the same, but the most common. Given a patient manifesting with ABCD, your diagnosis is supposed to be disease C. So what is or are the processes used? The main process is the pattern recognition, okay? But you have to make a decision which one is the more probable. So you go by prevalence, and that's the reason why you choose disease C, because it's the most common. So example here, another example. So try to solve it in your place now, okay? So which one is cleft lip? Which one is cleft lip and palate? Okay, just by looking at the pictures to come out with a diagnosis. So cleft lip is on the left side of the screen because it only involves the lip. Okay. Cleft lip and palate diagnosis is given to the one on the right side because the palate is also involved aside from the lip. So the process used here in the diagnosis is pattern recognition. Another patient presenting with bulging eyes and an enlarged thyroid or goiter. What is the diagnosis and what is the process used? So the pattern here is that of hyperthyroidism. Patients usually present with hyperthyroidism, usually can present with bulging eyes and enlarged goiter. Okay? So the process used here is pattern recognition. Patient has a cough. Another patient has a cough, colds, fever, and tiredness. What is your most probable diagnosis and what is the process used? Okay. So you have to choose from these 3 because all of these symptoms are being represented by 3 entities, possible entities: COVID-19, caused by SARS-CoV-2 virus, flu caused by influenza virus, and common colds caused by rhinovirus, different types of viruses, okay? But they present with the same symptoms. So what is your most probable diagnosis and the process used? So you have to choose COVID-19 in this time of pandemic and epidemic. So the process that you use is the prevalence process. Okay? Now, if COVID-19 is absent or is minimal, has been controlled, but you have now a flu epidemic or influenza epidemic or outbreak, then your diagnosis should be influenza. Okay, you're using prevalent process. The outputs of the clinical diagnostic processes are primary clinical diagnosis, meaning the most probable or most likely, and the secondary clinical diagnosis, or the alternate or second most probable or less likely. After the clinical diagnostic processes and formulation of the clinical diagnosis, the physician gives advice to the patient, meaning he tells and explains the findings and the diagnosis, and then he entertains and answers questions from the patient. This is what is meant by the advice on this part of the diagram. After the formulation of the clinical diagnosis, the physician decides whether he needs a paraclinical diagnostic procedure or not. Paraclinical here means done after the clinical diagnosis. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis, and you need to be certain or be more certain before the treatment, then go for a paraclinical diagnostic procedure. To decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes: the degree of certainty on the primary clinical diagnosis and comparison of treatment plans for the primary and secondary diagnosis. Illustration 1. If the degree of certainty is not is at 60 or 70, which is not certain, then you need a paraclinical diagnostic procedure. But if the degree of certainty is about 90 to 99, quite certain already of the diagnosis, then as a rule, you don't need your paraclinical diagnostic procedure. Okay? If the treatment plan for the primary and secondary diagnosis are the same, as a rule, you don't need any more. Okay. Another illustration. Okay. 98% certainty for primary. Okay. So if it's 98, it's quite certain. As a rule, you don't need any paraclinical diagnostic procedure anymore, even though the treatment of the primary and the secondary diagnosis are different. Okay. After analyzing the indication for a paraclinical diagnostic procedure, the next step is for the physician to advise. Look at this box again. The physician has to advise the patient on this by explaining the processes that he uses and the outcome of his analysis. He recommends, okay, he waits and answers queries from the patients and allows the patient to decide and forges a shared agreement. If there is a need for a paraclinical diagnostic procedure, the patient uses the physician uses the so-called VRCA processes. B stands for benefit, R, the risk, C, cost, and A, availability. The physician gives or lists the various options of paraclinical diagnostic procedures in this first column, and then gives the data on the VRCA. With the data given, the patient is asked, what does he prefer, or what do you prefer? Example, the accuracy for option 1 is 99%. This is the benefit. The goal is to be more definite. Okay. The option 2, 90%. Option 3, 60%. And low 60%. Okay. Risk, the same, almost the same. Availability, almost the same. But the cost for option 1 is 4,000. The cost for option 2 is 3,000. And the cost for option 3 is 1,000. So which will be chosen? So we ask the patient. The patient can choose option 1 if he can afford it. If not, option 2 can be chosen because the accuracy is 90% is good enough. Okay? So the advice given by the patient at this point consists of explaining the processes of selection using the BRCA to choose the most cost-effective paraclinical diagnostic procedure and to the desire of the patient. He can recommend, he waits and answers queries from the patient, allows the patient to decide, and forges a shared agreement. And assuming that a paraclinical diagnostic procedure is done, it's needed, it's indicated, so it's done. The physician has now to interpret the results of the paraclinical diagnostic procedure. To do this, he uses two processes. One is assessment of the accuracy of the report, and then correlation with the laboratory results or the results of the paraclinical diagnostic procedures with the clinical findings. Then he advises the patient on his interpretation and then proceeds to the discussion of the treatment. Before the selection of the treatment procedure, the patient decides, the physician decides on the pre-treatment diagnosis, which is obtained from repeated assessment of the accuracy of the clinical diagnosis and the paraclinical diagnosis and correlation of these two. He then advises the patient on the pre-treatment diagnosis. He spells out the objective or aims of the treatment. He then gives or lists the various options of treatment. Again, in column 1, uses the BRCA processes in the selection, gives the data on the BRCA. After the data are given, the patient is asked, what do you prefer? Example, greatest survival rate as the benefit for option 1, least survival rate for 3, and then for option 2, between 1 and 3, acceptable, okay? But the cost for option 1 is 5,000, option 2, 6,000, and then option 3, 3,000. All of these treatment procedures are readily available. So which should be chosen? Of course, the most cost-effective here will be greatest survival with the 5,000 pesos. You don't choose this, although this is 3,000, but it has the lowest survival. So you don't choose option 3. So the advice given by the physician at this point consists of explaining the processes of selection, the BRCA, to choose the most cost-effective treatment procedure and to the desire of the patient. Again, he can recommend, he waits and answers queries from the patient, allows the patient to decide, and then forges a shared agreement. Once a shared agreement is arrived at, the treatment is executed. Just before, during, and right after the treatment, the physician will have to advise the patient on the preparation, the outcome, as if the treatment has been executed, and the things to monitor, etc. After treatment, the physician advises the patient on health restoration and maintenance. So with this step, the last step, one whole cycle of patient management, inclusive of the involved processes, is completed by the physician and with full participation from the patient. That, in brief, is an overview of the ROJoson patient management process framework or algorithm. There are still a lot of nitty-gritty things to discuss or things to expound, but this will be done in subsequent sessions. Remember, I still have 5 sessions. So the takeaway in this pep talk that are related to patient empowerment, foremost, the ROJoson patient management process framework or algorithm clearly spells out the universal goals of treatment, the 4 basic categories of functions to be performed by the physician, namely rapport, diagnosis, treatment, and advice, and the involved processes that have to be done within each function. The problem-solving and decision-making processes for all health concerns do not simply utilize performing matching type questions and answers. They are more complex. They involve a series of actions which are carried out in order to achieve a particular objective or result. In understanding the patient management process being done by the physicians, the lay people will know how to participate in the problem solving and decision making of their health concerns with their physicians. With problem-based and self-directed learning, in the absence of the healthcare professionals, they may even know what to do with their health problems within their capacity and capability. And lastly, understanding the patient management process will redound to patient empowerment. Pagpapalakas ng pasyente through the K4, kaalaman, kakayanan, karapatan, and kapangyarihan. So I end this talk, patient management process and overview. I hope I have empowered you to have a better understanding than before of the patient management process, how a patient is being and should be managed. Thank you for your kind attention. Before we go to the open forum and interactions, so just a reminder, take the online learning home evaluation test exercise for mastery of learning and get a perfect score to get the certificate. The link has been given in the chat box. Okay. So let's now have a group picture taking before we start the open forum. Okay, ready? Ready na kayo? 1, sorry na lang late, ha? 1, 2, 3. Okay, so I'll just save it first. Save it on my let's have page 2. Page 2. 1, 1, 2. May pahabol. Okay na? 1, 2, 3. Okay. Okay. So the floor is now